Okay, let's start. Welcome and enjoy the beautiful lunch. I tried to tell Abbott to buy some lobster, but it was finished, unfortunately. Okay, so we have this session on access and closure, which I think is very important. I'm together with Maurizio Taramasso, Sergio Berti, and Ole De Becker. Nobody needs introduction here. Experts of complications as well. So we are here to share knowledge, to discuss openly. Please, I'm very happy to see a mixture of experienced people. People are less experienced, but the idea is that access and closure is a fundamental problem. We still have a high rate of complications. I'd like probably to start with one case I made a complication. These are my potential conflict of interest. And this is the learning objectives that I'm sure you already know. Otherwise, you would not be here, unless you came here just to get a sandwich. Most of you did this, huh? You are in the wrong room. Okay, so this is what you do not want to have. Okay, it's a vascular complication following a case. I will show you complication, and those who understand what happened at the end of the session, I wait for you outside. You tell me what happened. I have a prize for you. So it's a case of patient who had a degenerated trifecta. So high risk for coronary occlusion, and we decided to go for a basilica procedure. Basilica procedure needs a triple access. So we had a access for the eventual bailout chimney with was a radial access. Then we had another access for the basilica snaring and valve deployment, and another access for the basilica transversal access. You know, after the procedure, here you see the final outcome. Actually, the chimney was just ready for bailout. We didn't have to use the chimney because there was enough flow after the basilica. And this is the end of the procedure. We closed the access of the therapy access. The right access was the femoral, common femoral for the delivery of the procedure. The diagnostic so-called access is on the left side, and we see there is a failure of the closure. And the next step have been trying to get rid of that problem. Usually we try compression. We will talk about what to do. But after what we did, you can see here, this is the latest step. Watch this picture and try to understand what happened. If you understand, I would be very happy to give you a gift. Actually, there is a bleeding. But if you understand what kind of bleeding it is, it's not that easy. So without further delay, the message. We did a fantastic job on the valve, but we failed the access, which means access complications remain probably the most common complications after TAVI. So today we try to see how to avoid them. Okay. So for this, I'd like to start with the first step. I leave Maurizio. You are the spokesperson, so you will start introducing the steps.
Yes, I think we will now moving forward. The first topic is the CT assessment, and Ole will talk about CT planning of the transfemoral access for TAVI.
Yeah, thank you. I'll keep it brief. But of course, if we do TAVI and we want a good access, you heard access and closure is really important. So of course, it's really key that we pre-procedurally plan this as well. I mean, it's not going just in the lab and doing your echo-guided puncture. That's one important point. But I think we have all this CT to look for the access and make decisions. I think it's really important that we look at the CT and we take a couple of minutes to study and decide on what will be the best strategy. So first, when you have, this is from a case where I will show the next, also the videos from access and closure. So this is a case we did 2 weeks ago, I think. Classical case, transfemoral TAVI plans. So what you do is you look at first tortuosity. So is there anything particular tortuous, the left, the right, which maybe pushes you to do the case on to the left or the right side? I think here they're equally non-tortuous. There's hardly any tortuosity. You already see that on the left side there is, maybe if there is a pointer here, or I can maybe do it on the screen here. Yeah. So here you see on the left side, for example, that you see in this iliac, external iliac, that there is a circumferential 360-degree calcium spot with a 4.1 millimeter intraluminal diameter. So that's already not extremely attractive, but then it's also very important to look at the puncture site. And here you see the puncture site, there is some posterior calcium. You measure a 5.9 millimeter, that's probably large enough. But you do the same on the right side. You see that there is not this same circumferential calcification with an intraluminal diameter of 4.1. So looking at this, my preference would already go more to do the case from the left leg. Yeah. But that's not the only thing. So you look at through the whole vessel from common iliac up to the common femoral artery. You scroll through the whole artery and try to see where is it least calcified. And what is also very important, if before you take a final decision on your site where you're going to access, is where that common femoral bifurcation, the bifurcation between the common femoral and the superficial and the profunda is. And here you see, for example, on the right side, there is the bifurcation very nice below the femur head. You have the same on the left side. Let's say now that on the left side, this bifurcation would be at the middle of the femur head. That could still let me reconsider my strategy and maybe still go for the right side, because I do not want to puncture within 1 centimeter distance of the femoral bifurcation. If I have to bail out with stents, I do not want to stent over the profunda, for example. So here, that's a video, for example, here at the puncture site on both sides. So here you see, again, also at the puncture site even, there is some anterior calcium. So I like to scroll a little bit up and down to the part where I think my puncture will be. And if there is some anterior calcium, as it is in this particular case, I try to avoid this. And I think in this particular case, I definitely went for the right side, for the left leg. So here you see the echo guidance then. So first of all, you see nicely, what I try to do is, if I have my echo, this is a wireless echo, I try to put my artery in the middle of the screen. So typically you have here, for example, a small triangle or indicator of the middle of it. So I try to have that artery, which is a nice round structure. It's the round structure and it's pulsatile. If you really doubt, you can even put some color on it. But then now what I do is I compress a little bit on the subcutis, and then what you can compress is the vein. Yes, so the vein is typically it is the structure which you can compress. Here I'm going down to see where the bifurcation is, and I can clearly see the bifurcation. I see some posterior calcium too here on my artery. And what I will do next is I will go to a longitudinal view. And that's very important to do this longitudinal view, because you see here, this is the part where the artery dives in, it goes down, and that's not where we want to puncture. So I will go back maybe on this, or I will, yeah, so what I do actually here, you see this. So I have this longitudinal view. What I want to do at this particular point is, this is the diving part. I do not want to puncture there, because if I make my puncture, I will be able to do a puncture, but I have much more risk that my closure device, my ProStyle, will fail. Yes. So what I want to do is I want to do my puncture right here. I want to puncture it quite high, but not in the part that goes down, that dives down. So I put this in this longitudinal view in the middle of my view, of my echo view. And on that particular moment, if I have done that, I've centralized this part where I want to puncture in my longitudinal view. I will clock my echo, so I will get a short axis view. You will see me doing this now. I will clock my echo, all right? And then I have actually right here, that's the artery, the part probably it's mid-femur head, slightly above mid-femur head, where I want to do my puncture. So what is also really important here, I give the first thing I do is give some local anesthesia just for the skin. This is not yet for up to the artery. This is just to give some local anesthesia to the skin. And then the next one, you will see now, what I will do is to get some local anesthesia up to the artery. And if you want to do your transfemoral TAVIs in local anesthesia, as we do in Copenhagen, without any sedation, that's key. You have to give your local anesthesia just on top of your adventitia of your artery, because if you don't do that, your patients will still feel pain, you know. But if you do this very correctly, you can do this case really very nicely in local anesthesia. Sometimes I add even a little bit of local anesthesia afterwards. So now this is the puncture is done. Of course, the first thing I do is make a skin incision of roughly 6-8 millimeters. And this is to show you then the deployment of the prostyles. So we make first the skin incision. After this, we will go in with a 6 French sheet. So don't do, after your puncture, you always have to go in with a 6 French sheet. If you don't go immediately in with your prostyle, because then you will not be able to enter the artery, or you may kink your wire. So what you see here is that small wire that comes with the 6 French sheet. We go in with that 6 French sheet. That's just to pre-dilate it. We take it out. The video has just been shortened for sake of time. Then now the prostyle comes in. You see that the wire comes here on the side port, comes out. We push it nicely in until this white part where the wire exits just disappears below the skin level. You will see that. So we introduce it, we bring it forward into the vessel. This is now the moment to pull out this wire. So now I will be pulling out this wire. And then I take this prostyle 45 degrees nicely into the axis of the artery. So don't do it in an angle. Try to imagine where that artery goes and try to introduce it 45 degrees. If you have bleed back, now is the moment to, if you want to clock a little, then pull back, bring the leverage up. Yes, pull back, and now I shoot the needles. Yep. Now the needles have come out, and now I bring out the suture, cut the suture. What I do next is to bring this leverage down again. I move a little bit into the artery, bring it down, and I pull out so that I see this hub again. I take the two ends of this one suture. It's one suture, but it has two ends. I grab these, I put a small forceps on it, and I pull already a tiny bit on it in the direction of the vessel, of the artery. And then I go for the second one. Yeah, so now you see this hub here with the white indicator, and now the wire goes in. That could be either the short wire again, or it could be a standard J wire. So we introduce that, and then we do the same for the second prostyle. So I think that's what I wanted to show in this first video, and then we can take it from there for some discussion, and we can take it to the closure at the end.
So thank you so much. So first of all, I'd like to know from the audience, if you please raise your hands, who is using echo-guided puncture on a regular way when you do TAVR? Who is not doing that? Okay, and so there are few already doing this. For those who are not doing, I really suggest you learn this technique. It has been a tremendous improvement. I'd like maybe, Sergio, you can probably elaborate a little bit on the smart screen how to do echo-guided puncture. But I think, keep in mind, in my opinion, two messages already from Ole de Becker. Two messages. Number one, watch the CT scan and plan. CT scan is fundamental for planning, understanding where to go, what to do, the location of the bifurcation. And then the second one is go where you planned. So, and that is by echo.
I need the pen. It's
here.
It's not here. No.
Okay. Somebody took the pen out.
Okay. I know with the finger.
No, it's a mia.
Can you have a pen?
Let's see here. The previous ones, they keep
Can you use the back of this?
I'm not sure it works. I think it's
I think
Maybe the end of that.
Let's try. No, nothing. You can use this picture,
I should be able to come up to the big screen. Yeah?
and also should be on the screen there.
Exit this one. I will exit the presentation mode.
okay. Can we switch the?
Okay. Now it's
Okay. While we are waiting for the pen, okay. When you do the echo approach, and I suggest you to get the longitudinal view. You will have in front of you an image like this one. As Ole mentioned, to identify the bifurcation is the first step. It is extremely important because the main anatomical landmark. Then if you have to decide on the base of the quality of the vessel to do the puncture, for example, in this point. Okay, it's working. Perfect. Thank you, Ole. Okay. I suppose we want to do the puncture here. You rotate, as Ole showed, the probe 90 degrees, and you will have in front of you an image like this one, two vessels. The first step is to understand which one is the artery, which one is the vein. There are some tricks and trips. First, the color. The second is with a mild compression, the vein tends to collapse because usually the vein is more medial, but in the case that Francesco showed, the anatomy probably is inverted. So, if you put the echo probe here, the first and very common error at the beginning is to try to do the puncture very, very close to the probe. The result is that the trajectory of the probe is this one, and sometimes you don't see clearly the point of puncture because you are too proximal. I recommend this approach. This is a mathematical approach for a perfect puncture. You have to measure the distance from the skin and the vessel. You transfer this measure on the skin. You keep the needle with a 45-degree angle, and when you will advance the needle, you will be exactly under the echo beam. Okay? Francesco, I think we can go on.
I think, before we go on, once more, I want to stress one point. I see a lot of colleagues who are having on the left hand the echo probe, and then try to puncture without seeing the needle. I mean, if you use the probe, you need to really identify the tip of the needle. This is not an easy, it takes some time. You have to scroll with the left hand several times, but you need to be very sure that you are going to puncture the anterior portion of the artery, and as we have heard before, distant from the bifurcation. In my practice, for instance, the worst location for a puncture is the bifurcation. If you really puncture the bifurcation, zero opportunity to fix it percutaneously. Usually we always convert surgically.
Yes, because the main problem is when you do the puncture distally to the bifurcation. This is the real problem.
As well.
And especially if you do the puncture in the profunda. Because from a surgical point of view, to repair this vessel is extremely complex because the profunda is profunda.
Yeah.
Look, also, if you do this as a starter, I would think it's not forbidden to give a second of fluoro. I mean, what can really help, because you see the whole complexity is to really puncture at the correct height. So what is sometimes helpful if you're really a little bit lost, or it's an obese patient, or I still sometimes even do an obese patient too, then you take something, a metal object, metal forceps or something, and you think, you know from your pre-CT planning, I want to puncture right mid-femur head. Just place that object there, try to test. What costs you 1 second of fluoro, and sometimes you're surprised. You're like 3 centimeters too low. Then you know immediately, you don't have to explore there with your echo already. No, put it then higher up, and then you know already a little bit, okay, that's the spot of the correct height. That's where I'm gonna put my echo. And then you can even check it longitudinally, if it's correct. You see that you're away from the bifurcation, you're away from the diving part, and then you go to your short axis. But that can facilitate you of making big errors, I think.
There is a learning curve, right? Obviously, to have a good echo-guided puncture, and at the beginning you will get probably worse punctures using echo until you get used to it. And there are little differences also in the flow. For instance, I rarely use the longitudinal view because you can get the same impression of the diving by scrolling. But anyhow, because obviously it's very important, in my opinion, at the end to puncture the anterior wall, and that is really seen only in a transversal view. Maurizio.
We have a question from the chat, maybe for Ole. Is it needed to prepare the tunnel with schist, or maybe to do some dissection of the tissue before deploying?
I actually don't. No. I don't, even not if it's an obese patient with quite a lot of subcutis, I don't do it. No.
And then I have another question. Do you see any real advantage of using micropuncture set? Do you like it? Do you think it's just cosmetic? I mean, what's your opinion, and also the opinion of the rest of the panel?
No, I don't do it anymore. I did it very shortly. I did it for my transaxillary punctures but then in a way sometimes the needle is too flexible, you know, so then I also don't like it. I like more the rigidity of the classical needle. If you go 45 degrees, you know you go 45 degrees, because if you go for a micropuncture needle, sometimes if you make then these small adjustments, then you make actually a not straight channel, and that's these cases where then afterwards, if you want to go in with a sheet or with the probe like that, you get that S or a kink in the wire. So I'm not too big fan anymore of doing it, of these micropuncture needles. I don't know, maybe there's another opinion. But.
No, exactly the same. And we don't do I don't do the micropuncture. I use the standard needle, and it's important, as Francesco mentioned, or you use the longitudinal or cross-sectional, but it's important to identify the position of the bifurcation.
But I think this slide is very important. I see a lot of fellows passing in our lab, and unfortunately it just went away.
It was important.
Because I think that's the classical mistake. If you start with your transition, I see it on fellows when they start doing their first echo-guided punctures. What they do is because they want to see immediately the needle of the tip of the needle, and then they don't. So that's what Sergio was explaining. You start your puncture too close to your echo probe, and then to correct they go very vertical, and then they have the final puncture with a needle which is almost 80 degrees. But that's not a good recipe. Then you get also a kink in the wire or an S in your wire. So that's why I think the rule of Sergio is correct. You have to put, if you see you have your probe in your short axis, you see a vessel, it's in an obese patient, you see it at 3-4 centimeters. Also start to make your skin puncture at 3-4 centimeters distal of that echo, and then you will finally go 45 degrees, and then you will finally, at the end, you will see your tip of your needle. That's an important point.
Sorry, but talking about 45 degrees, this rule comes often. Why don't you show us the simulator to understand the importance of 45 degrees? Because this is another potential pitfall once you deploy, and this is very often, I've seen it often done using ProStyle, now is the new version. If you don't keep it to 45 degrees, you are spoiling actually the whole procedure, just for this little thing.
Yeah.
Why?
Okay, so this is just the initial puncture. You see, I will pause it for a couple of seconds just to explain what you see. That's just my hands on the simulator, but it's nice to look at the screen on the left. That gives you actually a view, of course, on this wet model from intravascular. So it shows you what happens into the vessel, and that's nice. Then if you see this video, for those who are not very familiar with ProGlide ProStyle, you know exactly what's happening, what you're doing when you're deploying this ProStyle actually. So I hope this is just a 4-minute video. So this is the puncture again. I'm explaining, you make your skin incision here. We have to pre-dilate the tract first with a classical 6 French sheet. I think that's coming here. It goes maybe a tiny slow here. I can go faster through it. Okay, it's just 4 minutes. But don't forget this. Don't go straight with your pro style, because that will not. The tip is not. It's too fluffy and it's not tapered enough. So you always have to pre-dilate a little. Then of course you take out your 6 French sheet, you compress, and then now normally you keep on compressing, and then you put your pro style on.
So why we see this? Because I think these are very commonly seen. We need to focus on the 45 degrees afterwards. Pro Glide, Pro Style. Did you see any difference? You know, when they came to me, it looked the same with a different color, but actually it works better. So why do you think it works better?
Well, what I know is that it's the needles are a little bit stronger. Mm-hmm. So you have less deviation of the needle. If there's a small, tiny spot of calcium, then it's more rigid. I think what's also been improved is, for example, this hub to cut your suture has been improved. You have this marker, but that I don't personally use a lot, these marker lines on that metal part. But here now, this is important. So here now you will see the bleed back. That's when you come in here, you will hear this is the bleed back. That's the moment. Then you know your anchor is actually in. And look at this now. So now when we put this up, this leverage up, we will get this anchor coming out, yeah? And that's why it's important, I will pause it here, that's why it's important when you do this traction, now we put the 2 fingers here behind to pull back on the pro style, and you see this is a nice 45-degree angle. That's why it has to be nice 45-degree, because then this anchor that came out intravascularly nicely is parallel with the vessel wall. I think that's what you wanted to show, yes, Francesco?
Yeah, I think it's very important to remember this. 45 degrees is the angle of that lever. Oh. So if you are keeping this more down, like 20, 30 degrees, you will not really puncture far enough from the edge of the opening, and this will reduce the ability of the suture to close. I mean, it's just a little detail, but please think about it. Think about importance of being also coaxial to the vessel, which means usually you go towards the belly button, okay? Because the arteries are actually going towards the middle of the body, and 45 degrees. And if you do this, this is a really effective device.
What I want to show still on this video, which is interesting, why do people instruct you that if you have now the needles have came out? So before you bring down this leverage, this knob 1 down again, it's important to come maybe push it 2-3 millimeter in again, intravascularly. And why is it? It's normal, because otherwise, if you wouldn't do it, you may potentially damage or hook up in some calcium on that vessel wall. You will see it on the video. I will let it play again. So now I push it a little bit in.
So just to say again, so you fire the needles, and prior to push down the system, you will enter a bit 1 millimeter in.
Yeah, yeah. Because then that anchor can nicely come into my system again, in my pro style, before I pull it out, and I will avoid interaction with calcium.
And look at this maneuver. So if you put it upside down, it will not fall out. I mean, everybody is a bit afraid of this pro style to get out of the artery. Put it upside down like it was before, and it will be very stable on the thing. You don't need any help.
Maybe another little detail that it was really clear. Once you open the feet, so you have bleeding, you open the feet, and then you pull back, you should check that there is no more bleeding. I think this is, if there is bleeding, you should not deploy, because it may get that.
That means that you are not in contact with the vessel.
Exactly. And that could be because you have maybe entered too far in, and then you opened up the anchor, but you're stuck behind a little bit of calcium, but you're still into the vessel, far too deep. Then it's better to close it down again, take it out again, go in. And that's also the thing, when you move in the beginning and you see the bleed back, don't go 2-3 centimeters deeper in, then you're far too deep in. It's more like when you go do this in a not too fast pace, go in, you see the bleed back, and then maybe advance maybe 5-6 millimeters. But that's enough. Don't go 2-3 centimeters in, because that's too far. If you then open your anchor, you only increase the chance that you hook up behind all kind of calcium, which is higher up in the vessel. Yeah.
So Ole, why don't we go and look at the real case? So we will then open for discussion, doubts, and suggestions from the audience. Maybe somebody is doing something different, which is a good idea. So if
this is just a closure. That's also a video of 4 minutes, and then I know it's finished. So what we do is we have, this is now a case with 2 prostyles. As you see on this one prostyle, you have the short one, the long one. I think most of you know. We will do the pull on the long one and not on the short one. So I'm putting my forceps here on the short one. I grab already the long end of the suture around my digit finger.
And you keep the suture, again, 45 degrees?
Let's see if I did it or not. I'm not sure.
Because this 45 remains through all the procedure, so it's easy. One number you need to remember, not so many.
I'll go quicker through it. Let's see, I think here. Yeah, so here we make ready. This is just after the TAVI case. So I grab this around my 2 digit fingers. Somebody will keep the wire in. I like to keep the wire in. And then I can still have my access and do something else if I need to. I can either add an extra prostyle, I can go for a plug-based thing. And then now the sheet is coming out. What I do is I pull on both ends, on the 2 long ends of the sutures. And then I grab, as you see here, a short demonstration, you grab the long end of the suture. You hold almost like a snare of a guitar, you kind of pull it up. And you see I will go in 45 degrees with this and wrap it around my digit finger, and then I do it with one hand and I push with my thumb on the pusher.
Yeah, this is another area where I see sometimes people doing a bit of artistic ways, like going in and out and pushing continuously. I see correctly what you do with one finger. You just push with the thumb, pulling on the index finger. Is very important, because actually what happens, this is not pusher. If you push this device too deep, then you can damage the artery.
Yeah.
So always have this concept that you are actually doing something that is somehow magic, because you have only 1 or 2 sutures to close an arterial opening, which is usually requires in surgery 10, 15 sutures, and this is done.
You see, this is the correct way to take it, yes, as Francesco described. So you pull the long one around your digit finger, as it is here, and then you have the best tactile feedback if you do then the thumb, use the thumb for the pushing on the knot pusher.
So really, there is no reason to do this maneuver, down. There is no reason, because there is a knot which is pre-prepared in the system. And it's a sliding knot, it's a fisherman knot that goes down and locks automatically. You have to be nice and continuous maneuver.
So then the last thing before we did this, so now I pushed on both long ends. So I think the only thing that I do now additional, I repeat it on both, and then I do, to lock my suture, I pull actually also on the short end. So as soon as you pull on the short end, then you kind of completely lock the suture, or the knot, sorry, you lock the knot, so then you can't push the knot lower down anymore, as soon as you pull on that short end. So I will do the same here on the other one, and then I pull on the short end. Yeah, and then actually we're completely finished. So you saw in the meantime I pulled out also the wire, and it's a very nice dry closure immediately, hemostasis. With the 2 prostyles.
Do you give protamine now or not?
Yeah.
How much? Full dose, half dose?
Yeah, a full dose. Well, full dose. I mean, let's say if I give 10,000 heparin, full dose. If it's a tiny lady like 5,000, 6,000 heparin, then it's half dose. Yeah.
Okay. I usually give only half dose protamine afterwards. What you do, Maurizio?
Yeah, usually half dose, depending on, I mean, if there is major bleeding, maybe you consider to do more. I am a bit afraid, even if it's not evidence-based, if there are maybe stent just put a few days in advance, I try to avoid it. Otherwise, yeah, I think regularly half dose is our practice.
So, questions from you guys?
Yeah.
Come, please.
Hello, Samir Wafa from Egypt. Sometimes if the patient is obese, you have to go perpendicular, so to be close to the arteries, to avoid missing the puncture. So what do you do in this case? You cannot go 45 degrees.
It's a good point. You know, the thicker the patient, the more vertical you need to go. So I agree with you. Sometimes we need to compromise. Yes, you can do that. I mean, it's not a big.
The other point, do you do ACT regularly to give protamine or not?
So
During the procedure, do you take a blood test for ACT?
Yeah.
And if it is high, you give a full dose. If it's a little bit low, give half dose, or no?
I mean,
or
I
not
think,
guided by ACT at all.
Okay, there is no I think general rule. My recipe, I keep the ACT between 200 and 300 or 250 target. At the end of the procedure, I regularly give half dose protamine. I will not check ACT. There's been also trials showing that reduces the risk of bleeding complications. But obviously, as Maurizio was telling, there are patients where you don't want to give protamine, and there are patients where you have bleeding, you want to give protamine. Opposite.
Third one question.
But then stop, basta. No, I'm kidding.
Do you regularly go from the other side retrograde to inject after doing the suture to check if there is any bleeding?
So me, yes. Either I have a contralateral approach or same side access. Each patient should get out of the room with zero evidence of a residual bleeding.
Yeah.
I want to sleep.
But I think it's mandatory to check, especially now that we tend to discharge the patient maybe even first day, to be 100% sure that you have no bleeding. So you have to check.
Yeah.
Then can be from the radial artery, can be from same side, can be selective, but you have to check.
Yeah. Thank you very much.
Maurizio, now we did it, but recently now we are checking with the echo.
Or with echo, yes.
With echo is fantastic because you see if you have bleeding, if you have pseudoaneurysm, the details of the echo is really very. If you develop an expertise with the echo, is fantastic, and you save contrast.
Please.
It's Dimitris Nikas, Ioana University, Greece. If I quite understand, you pull both strings together in the first time when you close, so you don't close one after the other. Because what we notice is sometimes even one ProGlide is enough to close the artery, and the second one may close the artery completely. That's why we did it. Actually, we do the first one, check the artery if everything's okay, and if then the second ProGlide close the artery completely, this happens sometimes, especially in tortuous arteries. We just cut the ProGlide. We have another one ready if needed, with the wire inside. But should we do this? I mean,
So
one after
sorry,
the other?
closing completely means that you have
Complete
occlusion of the
artery.
Well,
completely.
but this is not because of the second suture. It's basically because of the. You need really to be careful once you open your feet, and once you have back bleeding. What I do, I get out again to see exactly the location of the artery, and I don't go deeper than 1 or 2 millimeters to open the legs, to open the feet of the system. Because if you go too deep, you may get stuck into calcium and then close the artery because you deliver the sutures in between the artery. So, I mean, I agree with you that you can have different approaches, but usually, also in my practice, I close one and then second. But I don't check in between, to be honest.
I've never had an occlusion, to be honest. So and I've done always on if I use two, I pull on both at the same time. So I don't think it has to do with that, to be honest. I think it has to do with where you shoot indeed the needles more. Yeah.
If I may explain this a little bit better, we have two cases in which tortuous arteries may twist when you shoot the ProGlides. That's why we do this regularly. I mean, now we check routine between the two ProGlides. Because it happens to us twice.
Okay. There are questions from behind.
Yeah, Doug Fraser in Manchester. So I think we've been doing the wrong thing. So basically, what we were doing was deploying the anchor when we saw bleed back. But then we had a few cases where there was a vascular complication, and the surgeons told us that actually we deployed it in the tract. It wasn't in the vessel. So what we started to do was to look for bleed back, but then usually advance it a bit further in until we felt there wasn't resistance pushing it in. And I think from your description, we're probably pushing it in too deep.
Yes, this is you have in this case what you risk is that you get into the area of the femoral artery that dives into the iliac fossa, and therefore you will first of all you will not have any more the chance to deliver at 45 degrees because you have an angle that you cannot win even with your positions, and you may get the suture inside of the vessel. So again, in my opinion is that you really need to figure out in your mind where is exactly the depth at which you get the entrance of the artery, and don't go more than 2-3 millimeters beyond that level, otherwise you may get into trouble.
Just to comment on the last comment, I think there is a problem with doing 10 o'clock, 2 o'clock, which is common for TAVI. I think that does narrow the artery. We use a single ProGlide and an angioseal. It seems to work very well, and we never get the narrowing of the artery.
I think it's a good alternative. The problem of clocking, you should really be very careful not to clock too much. This has been, sometimes you have been clocking 45 degrees each one because it's nice to think the crisscross is good, but actually it's almost impossible.
Yeah, I fully agree. I don't do that clocking 10 and 2 o'clock, to be honest. So what I do is my first one always goes in 12 o'clock, and then I make a small clock on the second one, if I use the second one. Yeah.
There's another...
First of all, I have a follow-up question. When do you perform control angiography? Before the wire removal or after the wire removal?
That's a good question. Usually we do it after wire removal because usually it's guiding your decision is bleeding from the skin. And if you have a wire through, usually, so I don't know. Me personally, I look at the if there is no bleeding up from outside, I pull the wire and that's it. But I don't know what you do, guys. What do you do?
The same.
Yeah, I've actually changed my strategy the last 2 years to something super handy, and I don't like these controls from radial that's use a lot of fluoro. It's very often not easy. If I see people doing this, and what then if you see a bleeding? Then you're very limited in what you can do. Even then you're standing there with your radial approach, and then to get there a balloon or a stent, and even not, that's almost impossible. Contralateral also sometimes it uses a lot of time and it's not easy. So what I do is actually, when the TAVI sheet comes out, it's not shown in this video because of educational purposes, but if I take out the TAVI sheet, introduce the sheet, we pull on the ProStyle, and then we optimize as good as we can to close. We don't lock the knots yet, and then we go in with the 6-French sheet. And then we take the dilator out of the 6-French sheet, and we make a small 4 cc contrast injection through that 6-French sheet from that side. So it goes through your TAVI arteriotomy where you go. And if that looks great, there's no bleeding beside the sheet, there's no occlusion, whatever, then you can either, if it looked already dry before, you can finish off with your ProStyles, or if you go up front, as some colleagues go for automatically one ProStyle angioseal, for example, then you close it off with 6-French.
Excellent way. My second question is, I watched your video and there was no bleeding, even a leakage. Would you suggest such, or can we leave it with a leakage a little bit, just to be sure that there is nothing wrong?
There is nothing wrong to have some bleeding.
Not occlusion.
Left.
Nothing wrong that there is no occlusion.
So you can obviously always compress. My feeling is that if I exit the procedure, so at the end of the angiogram, there is no bleeding evidence, I feel much better than being there and compressing. I don't know what you do, guys, but we have been changing a bit. In the past we have been compressing for half an hour, 2 hours, 3 hours. Now I don't want to see that.
Okay.
But their echo can also add, yes. So I think I typically also don't like to accept even a continuous ooze. I don't like it. I mean, then you send your patient up.
Not a pulsative leakage, but just a leakage, not a pulsative.
Sure, but then you need to be on call.
Of course.
So the question is very simple. Yes, you can do it, but there will be 1 out of 10 patients that will call you in the middle of the night that the patient is hypotensive and yet to do CT scan. So I personally don't like that. I like to close the case.
Francesco, if you exclude with the echo that you are not problem at the vessel, we inject a small amount of adrenaline diluted 1 to 10, 1 cc for the subcutaneous small bleeding.
Yeah.
It's really effective.
Yeah, that's true. We do that too, but that's if you think it's the tract. Yes, it's you want to kind of, it's coming from the tract, the ooze, and then you give that a bit like adrenaline with lidocaine mix.
Yes, exactly. Yeah. But the first is to check that there are no problems at the vessel.
Of course. Thank you.
The advantage of the echo is you can do all the control that you want. You check before to remove the wire, you check after without contrast injection.
Last quick question and quick answer because we are over time.
Abdullah Al-Nazi from Kuwait. Just a quick question, quick comment. The first question is regarding the concern of the ProGlide being too deep. So what I usually do is once I have the foot up and I pull back, I look at the side arm, and if the bleeding stops, that makes me comfortable that I'm against the wall. But if it continues to bleed, then I'm concerned I'm not too deep. Does that make sense?
It's a good point, sure.
My comment is that when using ultrasound, the same technique you are using, just before I puncture with the needle, the last thing I do is I compress with the probe itself to see that that point that I'm about to puncture is compressible. Because if the ProGlide doesn't work, then your last bailout is to actually compress the vessel.
Very good. Thank you so much. So, unfortunately, I am the anchorman. The anchorman has to keep the time, and we are over time. It would be nice to, it's amazing we have been discussing over time for access and closure, but I really thank everybody for the presentations, and who understood what happened to my case, I will wait for you outside. Thank you so much. Have fun.